think that if one wanted to change pain education so that it was no longer upside down or backwards, the first thing to do would be to look at the adjective called biopsychosocial. We've all bought into that adjective, and I think there's nothing wrong with it intrinsically. But in practice, when we educate about pain, we take 85 or 90% of the time and devote it to the bio, about 5 or 6% and devote it to the psycho, and a little smidgen to the social. There are pioneers such as Beth Murinson or Judy Watson that have been working on placing emphasis on the social. So I would say in the ideal world, we should no longer refer to pain as a biopsychosocial phenomenon. Instead, we should refer to it as a socio-psychobiological phenomenon. We should put the majority of the emphasis on the social aspects, some on psychological, and perhaps in an appendix chapter for those who are interested on the mediators and mechanisms. Now, we've started to do this at Tufts. We were the first, and to my knowledge, only program to offer instruction about pain from literally a Department of Public Health and Community Medicine. If you ask the average clinician whether he or she thinks pain is a public health problem, they'll probably say, sure. And if you say, well, why do you think that? They'll say, well, a lot of people have it and it costs a lot of money. But that's just scratching the surface. What a public health viewpoint does is begin at the population basis and look at things in terms of systems. So if you look at public health approaches, say, to obesity, cellular metabolism is in there, but it's only a very small part of things. You have concepts like what types of crops are grown. Is there food insecurity? What marketing is there? What is the environment doing to the person who consumes food? What is accessible to them? So I'm not denying the role of cellular metabolism for the important phenomenon of obesity, but there's much more to it. Similarly with pain, we have to understand it as a social and population-based phenomenon. This does not mean that there is not accuracy and truth to looking at biochemical mediators, but we just find it very difficult, and I think people just withdraw and feel frustrated when they try to deal with the real world of everyday pain clinic patients, where there's a mess, there's disruption, there's family discord, there's economic strain, and they can't possibly explain or describe that in molecular terms. So if we wanted to look at pain as a socio-psychobiological phenomenon, and we did so as we've been doing at Tufts from a public health perspective, we would also offer courses that go above and beyond the standard curricula, such as the IASP curricula. We would offer courses in epidemiology. We'd offer courses in institutional change, because many people who learn about pain go out and want to reform their institution and find themselves frustrated because what they lack are the systems change tools, not the knowledge of biochemistry. But the knowledge of biochemistry gets you about as far as the knowledge of combustion physics if you're trying to organize a bus line. The bus line depends on combustion physics, but it's not really that important. It's more of a systems issue. So we offer those things and clinician-patient relationship, capstone projects that allow people, for instance, to participate in global health and see the impact of culture on pain. So I feel like in some respects we've been trying to lead a vanguard, and perhaps the world, thanks to the advent of fMRIs and sophisticated neuroendocrine studies, is catching up to the importance of social phenomena for pain.